Assalamu alaikum students, and we are continuing on with our ophthalmology lecture video sessions. Today we'll be talking about cellulitis, which is our final differential in the theme of ocular surface and lid anomalies. It is one of the more important conditions because one of the diseases that we'll study under the umbrella of cellulitis can potentially be life-threatening in addition to sight-threatening. We will be talking about the anatomy of the orbit and the Adnexa, and then we'll be talking about the types of cellulitis, how they present, how they are managed, and their complications. It is really important to recognize cellulitis in a patient at any level. By any level, I mean whether you're a pediatrician, you're a family physician, you're an internist, and especially if you're an ophthalmologist. But even if you are just a family physician or a general physician, you must be able to recognize cellulitis, be able to distinguish between the two types. And that's especially true in children where the presentation is sort of muddy and might require certain radiological investigation to differentiate between the two types of cellulitis. Why is it important to differentiate between the two? Is because one of them is potentially lethal to sight and also to life. And we'll start off by looking at the anatomy, and the most important structure for us right now is the orbital septum. And the orbital septum is basically the continuation of the periosteum of the bony orbital margin down into the lids, and it merges into the tarsal plates. The tarsal plates are the structure that forms the skeleton of the lid. It gives the lids its rigidity. And the importance of orbital septum lies in the fact that it's a barrier between between the tissues of the lid and the tissues of the orbit. Tissues of the lid are pre-septal, behind the septum or post-septal are orbital tissues, and it prevents infections from pre-septal area, tissues of the lid, to travel towards the orbit. Behind the orbital septum. Think of orbital septum as the septa that separates the various compartments in your forearm, and those compartments are there so that if you have an infection in one area, it doesn't spread to the other because you have that thick fibrous septa in between or partition in between, and the orbital septum here is doing the same thing. So before we start the animation, let's just have a look at this frame and study the structures that we can see. This whitish creamish structure is the orbital septum, and as you can see, it's a reflection of the periosteum of the bony orbital margin, and it sort of forms a 360-degree barrier between the tissues that are right here anterior to it, which are the lid tissues, and the tissues behind it, which would be the orbital tissues. It merges into these gray structures, which are the tarsal plates, and these fibers that you see are of these things that look like little twigs right here. These are fibers of levator palpebris superioris, and they pierce through the orbital septum to attach onto the upper lid. These two are ligaments. This is the medial canthal ligament, this is the lateral canthal ligament, and they're basically anchors for the tarsal plates to the margins of the bony orbit. Let's start this animation, and we'll see that this orbital septum is sort of continuous around the margins of the bony orbit. It has some openings, like for example here for the lacrimal gland. And if I remove the orbital septum, you can see that behind the orbital septum are the orbital tissue. So the orbital septum has a really important function in the sense that it is preventing infections from traveling from the lid tissues right here to the orbit, because if there was no orbital septum, like you can see in this picture, infections and everything else can freely travel through between the tissues of the lid to the tissues of the orbit, which would be devastating. So that is why this orbital septum is so important. And we brought it back to see how it acts as a barrier between the tissues here anterior to it, which is largely the tissues of the soft tissues of the lid, and separates them from the tissues of the orbit. It acts as a barrier. And if I can show you one picture, this is what the orbital septum is, this line as shown by these black arrows, which is the same structure as here, and it prevents infections from the lid tissues here and here from spreading back into the orbit. This is another picture this is a diagram actually, and this is your orbital septum. I'll just highlight it. This is the periosteal margin of your bony orbit, and between the two red lines is your orbital septum, which merges into the tarsal plates, which are these, which is highlighted by these black lines, the tarsal plates. And these are your two canthal ligaments, lateral and medial canthal ligament or tendons, which are anchoring your tarsal plates to the bony orbit. And these are the fibers of the levator palpebris superioris. We also saw it in the animation. It pierces through the orbital septum to attach on the upper lid. This is another view of the orbit and the orbital septum, and this one is also showing you the contents of the orbit. We'll just have a cursory look at the contents of the orbit before moving on. So this is the orbital septum. This is the superior half. This is the inferior half. This is a cross section. Thus, we are not seeing all of the orbital septum as we did in the animation or the diagram before. These are the fibers of the levator palpebris superioris as it pierces through the orbital septum to attach onto the upper lid. And this septum is obviously separating lid tissues from the orbital tissues. The orbital tissues are basically the orbital fat, the muscles, the optic nerve. Not shown in this are the various nerves and the vessels within the orbit and the ciliary ganglion. But the most important structures with regards to our topic today are the muscles and the optic nerve. And we'll see how their functions are affected when the orbit is involved in an inflammatory process. So this is a close-up view. Again, fibers of levator palpebris superioris coming through the orbital septum to attach onto the upper lid. We've seen this picture before, again highlighting the orbital septum and how it is a barrier between lid tissues and tissues of the orbit. So let's define cellulitis. Cellulitis is basically infection involving layers of skin and subcutaneous tissue. With regards to ophthalmology, we have two types of cellulitis. One is the pre-septal cellulitis, and as the name suggests, this is the infection of the skin or the subcutaneous tissue of the lids and surrounding tissue that is in front of the orbital septum. So all of this inflammation is happening anterior to the orbital septum. The other one is called orbital cellulitis. This is the infection of soft tissues of the orbit, which is behind the orbital septum. This is the potentially lethal type, both for the sight and also for the life of your patient, and is considered an ophthalmic or an ocular emergency. And it usually, but not always, starts off from a pre-septal cellulitis that is sort of not appropriately managed, or it basically presents late. The patient presents late, so as the pre-septal cellulitis has already converted into an orbital cellulitis. We'll start off with pre-septal cellulitis, and that is the infection in the tissues anterior to the orbital septum, which are basically your lid and surrounding tissue. So again, we have done the infection. We have done the definition, which is infection of the skin or the subcutaneous tissue of the lid or the surrounding tissues, which is in front of the orbital septum. This is mostly a benign condition as long as it restricts itself to the area that is in front of the orbital septum. It can affect any age group. It's most common in the extremes of ages and those who are immunocompromised. Now, by immunocompromised, I mean individuals who are diabetic, pregnancy, malnutrition, or those with HIV infections in addition to others. So the entire spectrum of a patient whose immunity is sort of suppressed would be included in this term immunocompromised. There are three ways in which the infection can get to these tissues. One is, and the most common, is contiguous spread. What happens is you have an infection in your paranasal sinuses that spread onto your pre-septal tissue. And this is the most common way that you get a pre-septal cellulitis. The other way is a direct spread. A direct spread is something that is affecting directly your lids or these structures surrounding the lids in front of the orbital septum, which would include a stye, insect bites, acute dacryocystitis, direct trauma, which introduces infectious pathogens to the lid or the adnexal tissue. And all of these can cause a pre-septal cellulitis. The other way is, or the final way, the third way is hematogenous spread, that is through blood, which you have sepsis, or you have, one of the ways is basically you have had a dental procedure done, which can spread on to cause a pre-septal cellulitis. The organisms that are most commonly found in pre-septal cellulitis are Staphylococcus aureus and Epidermidis, and these are found if the way that the organism affected the tissue was through insect bites or trauma. Streptococcus pneumoniae is if you have a pre-septal cellulitis that's associated with the sinusitis. So how does a patient present? Well, a patient is going to present with all signs of acute inflammation. They'll have red swollen lids, and at times the swelling is so much that the lid are closed, which is called mechanical ptosis. We have already talked about ptosis before. This is one of the causes of mechanical ptosis, but ptosis is something that is not always present, as we'll see in some of the pictures. You will also have a history or symptoms of the condition leading to pre-septal cellulitis, for example, a sinusitis, a upper respiratory tract infection, trauma, insect bite, history of Dacryocystitis. If you have hematogenous spread or spread from paranasal sinus or a dental infection that causes a pre-septal cellulitis, you might even have a history of fever. The signs are, again, tender, painful, swollen lids, which are erythematous and edematous. Edematous is swollen, erythematous is red. Signs of acute inflammation with or without mechanical ptosis. The eyes might be closed, they might be able to open. You will have some level of conjunctival congestion as well, simply because the palpebral conjunctiva, which lines the undersurface of the lid, continues on as the bulbar conjunctiva. So let's see some pictures. This is a pre-septal cellulitis of the right eye, and as you can see that the inflammation of the soft tissues is enough to cause ptosis. The patient can't open her eye. Well, this is a her in this case. This is a pre-septal cellulitis of the left eye, and this time the tissues are inflamed, as you can see, but the inflammation is not as severe to cause ptosis. This is what happens if your eye has mechanical ptosis. You'll have to forcefully open the eye in order to see the involvement of the conjunctiva. It is always essential to open the eye to see what's going on behind the lids if there is mechanical ptosis, because orbital cellulitis presents in a very, very similar way. This is another pre-septal cellulitis that started off as an acute dacryocystitis and has gone on to involve the soft tissues of the lid. You can see mechanical ptosis together with erythematous and edematous lids. So how the investigations are usually not necessary in adults because the diagnosis is straightforward. In children, or when you are in doubt, a CBC with differential and a CT orbit is indicated. A CT orbit is always indicated if you are dealing with pre-septal cellulitis in children, because you need to differentiate it from an orbital cellulitis. And as I said, the presentation can be very similar. And if a child is presenting with ptosis, mechanical ptosis, that child is not going to allow you to open the eye and examine it the way you would want to, and a CT scan thus becomes indicated. So this is what a CT scan of a pre-septal cellulitis would look like. There is a lot of soft tissue swelling in front of the orbital septum, and the orbit itself is pretty much clear. So the differentials are sort of important, as I said, and the most important differential is obviously an orbital cellulitis. Fever, proptosis, extraocular muscle restriction, and a decrease in VA, visual acuity, are all features that are specific to orbital cellulitis. But if you see these, proptosis, extraocular movement restriction, and decrease in visual acuity can only be checked if you open the eye. So forcefully opening the eye is essential when you are seeing a patient of pre-septal cellulitis. If you have a child, a CT scan is required and becomes indicated. The other differential is a non-infectious insect bite, in which you would see a place where the insect has actually stung the patient. You will have a history, and you have a very itchy skin, and in absence of extensive signs of inflammation, there would be a definite lack of the intensity or severity of inflammation that is seen with pre-septal cellulitis as compared to just an insect bite. Insect bite can cause a lot of edema, but not as much inflammatory signs. In terms of the lid might be edematous, it might not have the same amount of erythema as it would if it were a pre-septal cellulitis. But when in doubt, always treat. Dacryocystitis is easy because you have a history of epiphora before and a painful swelling in the lacrimal area in dacryocystitis. So how do we manage this? In adults and older children, it's usually a staph-sensitive amoxicillin together with clavulanic acid, which makes it augmentin, together with your non-steroidals. In adult, the dose is 1 gram twice a day till resolution of inflammation. In children, it's age and weight-based. Cultures, IV antibiotic, and hospitalizations are indicated if you get no response from your oral antibiotic in about 48 hours. In children less than 2 years of age, you always hospitalize. You take blood cultures from the source, the potential source. If you have an eye wound, if you have a paranasal sinus infection, you take secretions or paranasal sinus secretions as your culture medium. If you are suspecting hematogenous spread, do a blood culture. It is mostly an upper respiratory tract infection and paranasal sinus infection that becomes a pre-septal cellulitis, as we've already talked about before. You start off with your empirical IV antibiotic, again something that is staph sensitive, age and weight based, and IV and hospitalization simply because there's a high risk of orbital cellulitis, because in children the orbital septum is weaker, it's not that well developed, and a pre-septal cellulitis has more of a chance of becoming an orbital cellulitis, thus more intensive care or more monitored care is required. And again, empirical IV or whatever antibiotics are continued till resolution of inflammation. If the condition doesn't improve, obviously switch according to your culture report once the culture report is available. So switch antibiotics if no response seen once CS report is available. The prognosis is usually good if it is promptly picked up and promptly treated and appropriately followed up. It does have a chance of becoming an orbital cellulitis, and an orbital cellulitis can lead to CNS involvement, cavernous sinus thrombosis, meningitis, and blood abscesses, which can lead to, in addition to sight loss, also life loss. We will now talk about orbital cellulitis, which is inflammation of the soft tissues of the orbit behind the orbital septum. This is an ophthalmic emergency because it can cause sight as well as life loss. It is again seen in extremes of ages, again seen in most commonly in those who are immunocompromised. By immunocompromised, I mean those individuals who are diabetic, who are pregnant, who have malnutrition, who have an HIV infection. So this is an umbrella term, and we are using it just like we used when we were discussing pre-septal cellulitis. Although it is more common at extremes of ages, it again can be seen in any age group. The source of infection again is similar to that of pre-septal cellulitis. You can have contiguous spread from paranasal sinuses, which is again the most common cause, and the most common sinus that can transfer infection to an orbital tissue is the ethmoid sinus. You can have a direct spread from a lid or an adnexal tissue infection, like for example, a Dacryocystitis, trauma, which introduces organisms into these tissues, insect bite, and pre-septal cellulitis. This is more commonly seen in younger age group where the orbital septum is not well developed. You can have hematogenous spread, in which is a blood-borne infection, or you have dental infections which are spreading to your orbital tissue. The organism this time around is Staphylococcus aureus, Staph epidermidis, and Strep pneumoniae, and these are similar to what we saw when we were talking about pre-septal cellulitis. So what is the difference, or how do a patient of orbital cellulitis present? Well, the patient has red and swollen eyelids together with headache and eye pain, especially eye pain behind the eyeballs, orbital pain. There can be a history of decreased vision and double vision if the patient is presenting with a more severe infection or an infection that is in a later case, that is more advanced. You can have history of fever as well as painful and swollen lids, together with a recent upper respiratory tract infection as the most common presentation in children. And you would have a history or symptoms of any one of the conditions that can lead to a pre-septal cellulitis, as we talked about before, because pre-septal cellulitis can complicate to an orbital cellulitis. Fever is variable. Sometimes it is high grade. Sometimes the patient might be fever-free simply because he's already taking treatment for fever because of one of the associated conditions. So as you can see here, with the exception of pain, which is sort of more severe, the presentation can be very similar to that of a pre-septal cellulitis, unless the disease is more advanced and the patient is noticing problems with vision or problems with eye movement. So what are the signs? Well, you have very tender edematous and erythematous red and swollen lids together with mechanical ptosis. This time the mechanical ptosis is invariably almost always present. You will have conjunctival chemosis that is similar to what we saw when we were talking about pre-septal cellulitis. The distinguishing features are proptosis, and that is basically your eyeball is pushed forward because of all the inflammatory material or exudation in the orbit. The orbit has a fixed volume. It is surrounded by bone, with the exception of its anterior part where you have your eyeball, which can be sort of, pushed forward. But the proptosis is usually masked, almost always masked, because of the ptosis, the mechanical ptosis. Your lids are so edematous that they are sort of forcefully closed because of the mechanical weight of the edema, which is because of inflammation. And it requires forced eye opening. And again, I've been saying it again and again, you need to open the eyes of patients who presents with any type of cellulitis to see whether the infection is spread behind the orbital septum or not, because neither can you check visual acuity, nor can you check the pupils, nor can you check for proptosis, nor can you check for extraocular motility restriction without opening the eyes. So more advanced diseases or more severe diseases would present with proptosis, restricted eye movement, simply because there is inflammation of the orbital tissues, which can also spread onto the muscles, or just the inflammation in the orbital tissues is preventing your muscles from acting appropriately because there is no space for them, because the orbit is filled with inflammatory material. And the other reason is involvement of the cavernous sinus. Now you might ask, what does the cavernous sinus have to do with extraocular movements? Well, all the nerves that supply these extraocular muscles are invariably linked to the cavernous sinus. Either they travel through it or they are traveling very close to it. So if you have cavernous sinus thrombosis, which is a potential complication of orbital cellulitis, you will have extraocular motility restriction. Decreased visual acuity because of compression of the optic nerve, which is because of orbital inflammation, together with red desaturation. Red desaturation is red color appears as pink, and that happens because red is the most dominant color cone. And when you start losing optic nerve function, the first color whose appearance is altered is red, because it's the most common cone. So most common cone, when it stops working, you will feel its effects the most, because if it's the most common, its signals would also be most affected. Then you would have an RAPD, which is relative afferent pupillary defect. I'm sure you have done pupillary examination and you know what an RAPD is. It is because of unilateral optic nerve dysfunction. So how do we differentiate it from pre-septal cellulitis? Again, as I said, that unless you open the eye, it can be very difficult. From the history, excessive amounts of pain, especially those on eye movement, might alert you towards an orbital cellulitis. Fever, but fever, as we have talked about before, may be seen in pre-septal cellulitis, and it can also be masked by the medication that the patient is taking. The things that make orbital cellulitis and not pre-septal cellulitis is proptosis, ocular motility restriction, decreased visual acuity with red desaturation, and RAPD. And you won't be able to see any of these unless you open the eye. Opening the eye in a patient who presents with any type of cellulitis is thus very, very important. It is essential. So again, opening the eye is essential. I put it here in red simply because this is something you need to drill into your heads, that if you see a patient of cellulitis, irrespective whether it's pre-septal or orbital, you need to open the eyes to see whether you are actually looking at a pre-septal cellulitis or it is an orbital cellulitis. And in children, it's really difficult to differentiate between the two, warranting a CT scan. The differentials here are thyroid eye disease, which causes proptosis as well as extraocular motility restriction, and can also cause decreased visual acuity. So that is something to distinguish. But thyroid eye disease occurs in remissions and exacerbations. It might have symptoms of other forms of thyroid dysfunction, although that is not always true. And it is not something that you will see in a very acute setting without any antecedent history of some level of thyroid dysfunction or thyroid eye disease. Orbital tumors, again, can something that may make an orbital cellulitis, but again, they're not as rapidly progressive as an orbital cellulitis, and not associated with history of a respiratory tract infection, especially in children, or a paranasal sinus infection, or any one of the sources of infection as seen in orbital cellulitis. This is red desaturation. It is best tested with a bottle of Midrasil or atropine or cyclopentolate. All of them have red caps. They have red caps because generally you're not supposed to give these to patients who present with acute primary angle closure or secondary acute angle closure, simply because they make things worse. For primary angle closure, you have pilocarpine, and it has a green cap because it's safer in that condition, primary angle closure. That's why it has a red cap. Anyways, so red, as this is a normal color and would appear to a normal person, it would appear pink, as seen here, to a person who has red desaturation. This is a patient who has orbital cellulitis. You can see mechanical ptosis, and if you open the eye, you can also see proptosis, restricted ocular motility, together with decreased visual acuity and RAPD. This is a child, an 8-month-old baby who presented with upper respiratory tract infection together with an orbital cellulitis. And as you can see right now, all you have is erythematous and edematous lids. And the mark you see is basically to draw the boundaries of inflammation. And the way you see if your medication is working, if the inflammation and the edema or the signs of inflammation are actually reducing, so that they are sort of within the boundaries A, and there's a clear space between your mark and the area of inflammation. If the inflammation goes outside the boundaries that have been drawn, you know the your treatment is definitely ineffective, it's not responding, and the disease is getting worse. Thus this marking on the skin. It's a very simple thing which actually tells you which direction the disease is going and how effective your treatment is. But you need hospitalization for this and very careful monitoring. This is orbital cellulitis together with a concurrent pre-septal cellulitis. As you can see, white arrow indicating soft tissue inflammation in front of the orbital septum, and the orbit is also full of inflammatory material. You can also see that the source is probably a paranasal sinus from where the infection is getting into the orbit. This is an orbital cellulitis without involvement of the pre-septal tissue, just the orbit is full of inflammatory material, as can be seen, and this is as seen in the CT scan, the yellow arrow. So these are just the CT scans that we have seen. A pre-septal cellulitis only involves tissues in front of the orbital septum. Orbital cellulitis is behind the orbital septum, and you can have pre-septal and orbital cellulitis both together as well. So what investigations? Well, again, blood counts with differentials to sort of see leukocytosis. Blood cultures, nasal or throat swabs, as indicated by history and examination, are essential here, because you really want to know what is the infective organisms and make sure that if your patient is not improving with empirical treatment, you can switch based on evidence that you would have. CT scan is indicated in children, as we have talked about before, and in adults if you can't really say for sure if it's a pre-septal or an orbital cellulitis. And erring on the side of caution is always important, because as we have said, orbital cellulitis is sight and life threatening. So do a CT scan if you're not sure. That is why we have these investigations. They aid us. And when we are in doubt, it's always better to err on the side of caution. When it comes to management, this condition is treated as an emergency, and you need to sort of show the urgency and also demonstrate urgency that's required and demanded by this condition. Because if you don't, you can have sight loss as well as life loss. You can have sight loss because of optic nerve compression. You can have the infection spread to cavernous sinus thrombosis, which can lead to other CNS complications, including meningitis, brain abscesses, and eventually death of your patient. Cavernous sinus thrombosis simply because the orbital soft tissues as well as the lid soft tissues eventually drain into superior and inferior ophthalmic vein, which actually then drain into the cavernous sinus. The pre-septal tissue also have some other pathways of draining, but they eventually also, a component of them, drain into the cavernous sinus. So how do we manage this? Again, because you can have infection coming from various sources, and you can have your patient at various age groups. You might need an assistance of a pediatrician, an ENT surgeon, an ophthalmologist, an infectious disease specialist, and in addition, you might also need a neurologist or a neurosurgeon. you need to hospitalize your patient, you need to provide IV antibiotics, and the IV antibiotics part is in bold because you don't start with oral here. And the preferred antibiotic is usually a third generation cephalosporin together with metronidazole, depending upon your suspicion. And you start these as empirical after taking your CS and switch to CS if there is no improvement after the CS report is available. Remember, that is why we had that line drawn around the area of the inflammation visible in the child's picture that we saw. IV non-steroidals, and we check for optic nerve function, and that could be visual acuity, or if it's a child and if the patient has an RAPD, you check for an RAPD. And if you have improvement of optic nerve function after 48 hours, you can switch to an oral antibiotic. If the optic nerve function does not improve within 48 hours, you require surgical drainage of the orbital inflammatory exudate and any abscess if it has formed, and you require again an oculoplastic or an orbital surgeon or a neurosurgeon with requisite experience. The complications of this disease: sight loss, we have talked about this; cavernous sinus thrombosis, we have talked about that; meningitis, brain abscess, and eventual death. We all talked about these when we talked about the management and why we need to treat this as an emergency. Thank you very much. This is a really small topic, but it's a very, very important topic. It's essential that you are able to pick up a cellulitis. It's essential that you can differentiate an orbital cellulitis from a pre-septal cellulitis. And if in doubt, especially in children, and a CT scan is indicated to differentiate between the two conditions. And always take support from your colleagues, pediatricians, ENT surgeons, ophthalmologists, if you are a family physician who has seen a patient and who is unsure. There is no harm in asking for help. That is why we have so many subspecialties, and asking for assistance is always better than erring, and that would result in loss of sight or loss of life. Thank you very much, and I'll see you in your next session.